एक क्लिप कर बट इट चलो बट इट हाँ स्टार्ट लेकर
Good morning, Neeta.
Good morning, ma'am.
First slide is itki छान है.
Thank you, ma'am. You have started the series rolling, so
मीटिंग चालू है Neena, shall we start?
Start करायचे?
So let's start.
Okay, okay.
Good morning, everybody. Welcome you all to this session of Maharashtra Rheumatology Association PG session. Thank you very much for joining in big numbers. Last time we had almost 90 participants for the session, and we hope we will live up to your expectations. We did have a few technical glitches last time, but I'm sure we'll be better henceforth. Uh, I'm happy to welcome Dr. Dr. Neena Chitnis. She has been one of the main pillars of these PG sessions. She is a consultant rheumatologist attached to Leelavati Hospital, Sushruta Hospital, and Raheja Hospital. And she would be talking about clinical examination in rheumatology. Last time we discussed about the history taking. Today, let's have a look at clinical examination in rheumatology. And this is a practical session with a lot of photographs and videos. A few housekeeping requests to all of you. Please keep yourself on mute so that the speaker is not disturbed, everybody else is not disturbed. And secondly, last time quite a few of you had put in the this thing in the chat box about the request to get added to the WhatsApp group. All this happened towards the end of the session, so I really couldn't capture it later. So if you want to get added to the WhatsApp group so that you can be updated about the upcoming sessions, do put it in the chat right away. All your questions, we would have the session followed by question and answer. So as the session is going on, or once the session is over, you can always put your questions in the chat box. I'll be taking those. I'll be taking up all those questions. Thank you. Over to you, Neena.
Thank you, Dr. Shashank, for the introduction. Thank you very much. So this is the second lecture of our lecture series. Good morning, everyone. In the last lecture, Varsha madam has beautifully explained to you all how important is the history taking in rheumatology. So elaborate history taking is the first point to reaching to a diagnosis in our rheumatology cases. After a history taking, today we will discuss about the clinical examination in rheumatology. So diagnosing a patient in rheumatology is like the story of the elephant and the six blind men. Unless you take together the history and the examination of all your systems and the laboratory all together, then only you can diagnose your patient rightly. So everything has to be done in detail, and then only you can come to a proper conclusion. Now, over the time, a lot of investigations and radiology have taken over the importance of a good clinical examination in the other fields. So, for example, if a HRCT shows a interstitial lung disease, then there is an interstitial lung disease. So I may have missed the crackles or the creps on the auscultation, but if a good CT scan is showing a ILD, there is a ILD. Similarly, I have been through residency, we have missed murmurs in auscultation. But if a good 2D echo shows a mitral stenosis, so there is a mitral stenosis. You might have missed it on the auscultation. It doesn't matter, it is there. But rheumatology doesn't work that way. So in rheumatology, if you have a positive rheumatoid factor in the blood investigation, it does not mean that the patient does have rheumatoid. You have a positive ANA, it doesn't mean that the patient has lupus. And on the other hand, you might have a patient who has a full-blown rheumatoid arthritis, but the rheumatoid factor and the anti-CCP may be negative. So that means in rheumatology, the only thing what matters is the clinical examination and the history. Everything else comes later. So let's begin with a case. Let's begin with a case to show the importance of a good clinical examination. So there was this middle-aged female, a patient of rheumatoid arthritis, had been well controlled for many years on hydroxychloroquine and been doing fairly well only on hydroxychloroquine. She had some gallstones. She underwent cholecystectomy for that. On the follow-up, when she was doing her routine labs, the liver enzymes were largely elevated. So they were around about 300. She was thoroughly investigated, including the liver biopsy, but no cause was found for her elevated liver enzymes. She had stopped her hydroxychloroquine, of course, because of the elevated liver enzymes, the surgery, and all the investigations. So she was sent to the rheumat OPD because she had some shoulder pain that was attributed to the flare of her rheumatoid arthritis. When she came to the OPD, I examined her shoulder movements. The shoulder movements were restricted. She could hardly abduct her shoulder. So definitely the first impression was, yes, there is a shoulder involvement due to the rheumatoid. But whenever you see any restriction of the active movements, you perform the passive movements. And while doing the passive movements, I was surprised that she could completely abduct her shoulder. There was no restriction of any movement of any sort at the shoulder. Whenever your active movements are restricted and there is a problem in the passive movements, that generally means that the joint is normal. The problem may be in the muscle or the nerve. So when we examine this patient in detail, she was found to have gross proximal muscle weakness. She had grade 2 to 3 power in the upper limbs as well as the lower limbs. All this was attributed to weakness, fatigue because of being post-op and not being very ambulatory. We ordered for a CPK. The CPK came to be 7,000. So all this time, the liver was never the issue. It was myositis all along. So this case is to tell us that if we don't examine the patient clinically, only the investigations is not going to get us to the diagnosis. So when you're taking a good history, at the same time, somewhere in your head, you're making a note of your differential diagnosis. So when the patient is telling you about the complaints, little by little, you are making a list of all the DDs, what the patient could have. When you're doing an examination, your examination is going to be focused at that differential diagnosis. So in detail of that, what you have been suspected. So for example, if the patient, while telling you the history, has told you about polyarthritis, so the patient has pain and swelling in redness in the joints, somewhere you think, yeah, this could be rheumatoid arthritis. In such a patient, you are going to examination the joint in extreme detail. If a young patient has come to you with only inflammatory back pain, you somewhere have been thinking, yeah, this could be an ankylosing spondylitis. In the examination, though you will examine all the joints as well, you will do a detailed examination of the axial skeleton. In the history, if the patient has told you about a lot of systemic symptoms, so fever, rashes, weight loss, you are thinking of some connective tissue disease like lupus. In such patients, with the musculoskeletal examination, it is very important to see the skin, the oral cavity, and other systems like the respiratory, cardiovascular, and the neurosystem. So everything has to be examined. So let's start with, when do you start the examining of the patient? As soon as your patient is stepping into your OPD, you have to observe the gait of the patient. So if the patient is coming with an antalgic gait, that means that there is some problem, maybe in the hip, in the knee, or in the spine. If your patient is walking with a waddle, so you must have seen many of the older females coming, walking exactly with a waddle. So most of the time, they have either proximal muscle weakness or a knee issue. Generally, it is osteoarthritis. If the patient comes with a high steppage gait, he could be having a foot drop. So this was a patient. See the way she is walking. This patient had myositis. She had proximal muscle weakness, and you can see how she is putting her steps. So this sort of gait will, at the beginning only tell us that yes, this patient might be having some proximal muscle weakness or myositis. So how do we examine the musculoskeletal system? Each of the joints are to be examined for 3 things: swelling, tenderness, and limitation of motion. You always have to do an inspection and then palpation. Whenever you're examining a joint, you have to examine it as swelling and tenderness and grade it as 0, 1, 2, 3, tenderness as 0, 1, 2, 3. Swelling 0, 1, 2, 3 means no swelling, mild swelling, moderate swelling, severe swelling. Tenderness 0 means no tenderness. 1 means mild tenderness. 2 means tenderness and the patient winces with pain. And 3 means that the patient winces with pain and also withdraws the joint because of the pain. So let's start with examination of the hand. So when the patient comes to you and is sitting in your OPD, so what you will do is first examine the PIPs and the DIPs. Don't go to examining each PIP individually. First, just squeeze all the PIPs together and see for any tenderness. So now, if you find any particular joint which is swollen, with 2 fingers, feel and palpate the joint. When you're palpating the joint, try to see whether the swelling is bony or boggy. So as we know, the PIP joints and the DIP joints are many times involved in osteoarthritis. In osteoarthritis, the swelling will be more of a bony swelling. There will be less tenderness. While in a disease like rheumatoid arthritis, the swelling will be more boggy. So try to judge this when you're examining the joint. So with both your fingers, press and palpate the joint which you feel is involved. After that, go on to the metacarpophalangeal joints. Just give them a squeeze. So this is what we call the MCP squeeze. See for any tenderness in any joint. Again, if there is tenderness, palpate that particular joint with your 2 fingers. After the MCP, go to the wrist. Do a extension, a flexion. See for any restriction of movements. Now, other than arthritis, the common involvement of the wrist is in tenosynovitis called de Quervain's tenosynovitis. This is a tenosynovitis which affects the tendons along the thumb. So, common cause of wrist pain, only isolated wrist pain, is de Quervain's tenosynovitis. How do we check for it? So, tell the patient to put the thumb inside and clench the fist. Then you flex it toward the ulnar side and see for any pain along the radial side. If there is a pain, this shows that the patient has de Quervain's tenosynovitis. Along with the joints, it is other things that affect the hand are carpal tunnel syndrome or tenosynovitis in diabetes. So all these things also should be checked. See for any atrophy of the thenar muscles and the hypothenar muscles, which will be seen in patients who have carpal tunnel syndrome. At the same time, also see for a power. So just tell the patient to grip your finger. That will tell you about the range of motion also and about the power in your distal muscles. So as I was telling you, this is 2 patients. This patient, if you see, has predominant involvement of the distal interphalangeal joints with sparing of the proximal interphalangeal joints. This patient has nothing on the DIPs but a swelling in a proximal interphalangeal joint. So this patient had osteoarthritis and this patient had rheumatoid arthritis. So during our examination, we have to see these things because in osteoarthritis, we don't really investigate the patient too much. So we don't go for investigations like CCP, RA factor unless indicated. So it will save the patient a lot of finances if we diagnose a patient of OA as a OA. As I said, other than your joints, the other thing what affects the hands and causes pain and paresthesia is carpal tunnel. To know the carpal tunnel, we see for a Phalen's test, a Tinel's test. At the same time, not for carpal tunnel, but for diabetic tenosynovitis, we see for a prayer sign. Let's go about it. See, in Phalen's test, you are going to flex the wrist to 90 degrees for about 30 to 60 seconds and see for any paresthesia in the fingers. This is a prayer sign. So patient of diabetic tenosynovitis will not be able to properly approximate the hands. There will be some gap left between the hands. This is because of tenosynovitis in the tendons of the hands. In diabetic patients, you have a lot of tenosynovitis, trigger finger. So all these changes could be attributed to diabetes. Now this is Tinel sign. You have to just tap the location of the medial nerve and see for any tingling in the fingers. This will be positive in carpal tunnel syndrome. Now, other than the joints, there are many things which can tell you about connective tissue disease when you examine the fingers. So if you see here, they are digital infarcts. So the fingers in scleroderma, in vasculitis, in dermatomyositis, you will see digital infarcts at the tip of the fingers. Many times these infarcts are not fresh. So you will see scars telling you about past digital infarcts. If you see this is a digital gangrene. It can be seen in vasculitis. It can be seen also in severe scleroderma having severe Raynaud's leading to gangrenous changes in the tip of the fingers. Just see this. These are changes at the nail bed. This is called nail bed vasculitis. It is seen in diseases like dermatomyositis and also scleroderma. If you see this is called Raynaud's syndrome. So a patient many times may not tell you that the patient has discoloration of the fingers, but when patient is sitting in your OPD, generally when the AC is on, you might appreciate the turning of the fingers tip to white or blue. Sometime if you want to elicit it, you can turn on the AC on very cool, or even tell the patient to put the hand in flowing water and see for any color changes at the fingertips. Again, if you see this, these are papular rashes on the hands. This is Gottron's papules, which you see in dermatomyositis. This is mechanic's hands, which again you see in dermatomyositis. This is the nail in psoriasis. So again, the patient may not know what is psoriasis, may not correlate that psoriasis can cause arthritis. Many times on examination, we find these changes like they may be pitting, they may be onycholysis or discoloration of the nail, which is seen in psoriasis and psoriatic arthritis. After the hand, we go to the elbow. Now, in the history, if the patient is telling you of isolated pain only in a single elbow, many of the times it is due to local tendon inflammation rather than any systemic arthritis. So it is important to rule out these causes because it will save a lot of investigation. So if a patient has a local tendon inflammation, we do not require any investigation in this patient. So the medial and lateral epicondylitis is called tennis elbow and golfer's elbow. So lateral epicondylitis is called tennis elbow. Medial epicondylitis is called golfer's elbow. So in your examination, you have to also examine for this. So as I said, examine for the tenderness on the medial epicondyle, tenderness on the lateral epicondyle, and tenderness on the bursa. So the patient also could have olecranon bursitis. So see for tenderness at all these 3 points and then start seeing for the range of motion. See for the flexion at the elbow. See for the extension at the elbow. Also see for the fibromyalgia point there. So below the elbow is a common point for fibromyalgia. See for tenderness at that point. Okay. Now, generally, whenever there is elbow involvement in arthritis, usually there is some limitation to complete extension and the patient has a little bit of flexion deformity. So that is the way you will be able to differentiate between a tendon inflammation or a elbow involvement in arthritis. Along with the joints, again, just like the hands, you have to examine the skin. You have to see for any psoriatic patches. Again, I am telling you that the patient many times doesn't even know about these patches. So you have to look for it. Look for the psoriatic patches around the elbow. These are rheumatoid nodules, which you may see around the elbow. And this is a gouty tophi. So A tophi in gout, which can, elbow is a common site for occurrence of a gouty tophi. Now, see, this patient came with only swelling of one finger. The swelling was not particularly on any PIP or any DIP. The entire finger was swollen. This is called dactylitis or sausage finger. There was no other complaints in any other joints. On being asked, the patient did not tell about psoriasis, but on examination, I'm sorry, the photo is not very clear, but he had this very small patch of scaly skin at the elbow, which turned out to be psoriasis. So this patient had psoriatic arthritis. It is very important to check for the fibromyalgia spots, because fibromyalgia is a very common cause of pain in the patients who come to our OPD. So alongside with the joints, you will also examine for these trigger points. So these are some trigger points which you have to press with your thumb and see for any tenderness. The most common points which are involved are just below the elbow, the nape of the neck, the back. This is called the trapezius. So generally what we call this here tenderness is called trapezitis, tenderness near the occiputs. So these are the common points of tenderness, and tenderness in the medial side of the knee. Fibromyalgia is a very common condition, and that should not be missed when you are examining your patient in your OPD. After the elbow, we go on to our shoulder. Now again, like the elbow, if a patient has told you about isolated involvement of the shoulder, most of the time the patient might have a local shoulder problem like a tendinitis rather than an inflammatory arthritis. There are many conditions which affect the shoulder, like painful arc, adhesive capsulitis, rotator cuff. So while examining, we will be able to have a judgment of these things. So in painful arc, while abduction and adduction, there will be pain between 30 to 60 degrees. In adhesive capsulitis, there will be restriction of all movements, abduction, internal rotation, external rotation. Generally, in rotator cuff injuries, there will be pain and restriction mainly in abduction and external rotation. So just let's see. And in the shoulder, always examine first the movements actively, and then the same movements you examine passively. And after that, also check quickly the power at the proximal muscle. So all this can be done at one go. Tell the patient for complete abduction. Okay. Then tell the patient for internal rotation. Tell the patient to do an external rotation. After that, same movements you will do passively, again to see for any painful arc, any restriction of movements of external rotation, abduction, internal rotation. At the same time, you will also see for the tender points of fibromyalgia. Okay. So after this, you will also examine the neck, see for the neck movements, the lateral flexion, extension. So many times in the history, the people confuse between the pain coming from the shoulder and the pain coming from the neck, because the shoulder pain can also radiate to the cervical spine and the hands, and a cervical radiculopathy also can cause a similar type of pain. So during your examination, you will be able to judge whether the pain is coming from the spine or from the shoulder. Don't forget to look for pulses. So see for the radial pulse. If you find any discrepancy in the pulses, here for bruits, so carotid bruit, subclavian bruit, there might be discrepancy in the pulses in diseases like Takayasu's arthritis and even in thoracic outlet syndrome. So here I'll just like to tell you a short case. So this girl came into the casualty with loose motions. They found that her radials were not felt. So she was rushed to the ICU, considering that she is in hypovolemic shock. So when she was taken to the ICU, when her manual blood pressure was taken, the blood pressure was fine, but the radials were absent because this patient actually had Takayasu's disease. Nobody had ever felt her pulse, so that Takayasu's were never diagnosed. And that is why it was thought that this patient was in hypovolemic shock. So it's very important to check for the pulses for any patient coming into your OPD. It will not only tell you about tachycardia, but also about any tachycardia, any bradycardia, any irregular pulses. So it's very important to check for it. After the hand, we go on to the face. The face tells you a lot things about all connective tissue diseases. So if you see, maybe the rashes may not be very clear, because in Indian patients, because of our skin color, we can't appreciate the rashes very much. But if you see, she has some malar erythema around the cheeks, some rashes along the eyelids. So rashes along the eyelids will be seen in SLE and also in dermatomyositis. You will see a malar rash in patients of SLE. The ear, many times the rashes of SLE will be seen in the ear. Even when these rashes heal, they are left with hyperpigmented areas. So this is like a telltale sign of lupus. See, for alopecia, the SLE can lead to scarring as well as non-scarring alopecia. Many of the times the hair is very brittle. So in history, the patient will tell you about a pillow sign, that there are a lot of hair in the morning on the pillow. And when you will see a lot of brittle, unhealthy hair and maybe some bald patches also. Again, in SLE, this is just a clear picture of a malar rash. Always examine the oral cavity. So this is called a palatal erythema. Palatal erythema is very typical of acute lupus. So you will see redness on the palate. You will see for any ulcerations. So like these ulcers can be seen in lupus as well as in diseases like Behçet's disease. In scleroderma, the face will tell you a lot of things. So usually a patient of scleroderma, if they have florid scleroderma, you will be able to make out as soon as the patient comes into your OPD because of the scleroderma face. The face will be mask-like because of the tight skin, the loss of the subcutaneous tissue. You will see the eyelids are very taut. You will not be able to evert the eyelid easily. The nose will be pinched out. See, for mouth opening, the mouth opening will be reduced. They will be telangiectasia. So in patients of scleroderma, many times, these patients bring their photo with them to tell you how they used to look before and how they are looking now. There is so much of face changes which come in these patients. Now, also in these patients, we should check for the pinch test. I not have a photo of that, but you're supposed to pinch the skin on the forearm. Usually we can pinch the skin very easily, but in patients of scleroderma, because there is thickness of the skin, you usually even cannot generally pinch the skin in your 2 fingers, which is very typical of scleroderma. The ear, now this is not a very common condition. Inflammation of the cartilage of the pinna is seen in autoimmune disease like relapsing polychondritis. Also, the ear is a common site of psoriasis. So just like your elbow and your nails, you can see the signs of psoriasis in the ear, which the patient might miss telling you. Also see for oral candidiasis. For Sjogren's, you will see for dry mouth. So there you're supposed to see for the salivary puddle below the tongue. Also, when a patient has lot of caps and crowns and dental decay, that is also an indication that the patient has dry mouth. Check for parotid swelling again for Sjogren's. Check for any TM joint tenderness. In rheumatoid patients, the temporomandibular joint is also involved. See for any cervical lymphadenopathy, which may be present in patients of lupus. Now, after the examination of the face, now we will make the patient lie down and examine the joints of the lower limb. So, starting with the knee. So, when you're examining the knee, this is called a patellar tap sign. You're supposed to just press down from above the suprapatellar fossa and then tap the patella down towards the bone. Whenever there is an effusion, the patellar will go and hit the underlying bone and you will get a feeling like a tap. So this is suggestive of a knee joint effusion. Then you see for movements, a complete flexion, a complete extension. Now, while swing for the flexion and extension, you will also put your hand on the knee to appreciate crepitations, which you will see in a patient of osteoarthritis. Generally, when there is knee involvement, there may be restriction of the range of motions. The flexion might not be complete. The patient might have a flick flexion deformity. So all these patients should be noted when you are examining the knee joint. After the knee joint, let us go on to the hip joint. In the hip joint, what we will do is you do a flexion, a abduction, and an external rotation in a figure of 4. Doing this, now we will force a extended external rotation. So press the knee. Now this maneuver will tell us few things. If there is tenderness anteriorly at the hip, there is involvement of the hip joint. If there is tenderness if there is pain at the opposite side sacroiliac joint, there is involvement of the sacroiliac joint. So this is called sacroiliac joint stress positive. Okay. Then see for the movements at the hip joint, internal rotation, external rotation. Now at the same time, when you're examining the hip joint movements, same time you also saw for a sacroiliac joint movement. See, in your OPD, you do not have so much time that you're going to do each joint test individually. So where things can be coupled, do them together. Now at the same time, you also want to examine a pain of sciatica. So many times it's confusion when the patient tells you of pain, whether it is coming from the hip, whether it is coming from the SI joint, or whether the patient has any disc involvement, for which we are going to do the straight leg raising test. For the straight leg raising test, we have to completely flex the hip, keeping the knee extended. So this is how we are going to do it. Keep the knee extended and flex the hip. Whenever there is pain in the buttocks between 30 to 70 degrees, it is suggestive of involvement of the disc. If the pain is beyond 70 degrees, it may be due to the hip joint or the straight leg raising test. Now you are going to make the patient stand. Now, ideally, what we do for examination of the back whenever you are suspecting a spondyloarthropathy is a modified Schober's test. In your routine practice, in your OPD, you may not be able to do a Schober's test each time. So if the movements of the patient are normal, you do not need, a scale and a ruler and a tape to keep measuring the movement. So just make the patient do an extension, a flexion, a lateral flexion. So do an extension. Tell the patient to flex completely forwards. See for any limitation of movements of the back. Don't forget to see for lateral flexion. Many of the times in spondyloarthropathy, the first movement to be limited will be the extension and the lateral flexion. So don't forget to see for these movements also. So if you're actually doing in the examination of the spondyloarthropathy, you will need to do the modified Schober's test. In this, what you will do is point the midpoint between the PSIS. So take the midpoint, take a tape and take 15 centimeter above this point and mark it. Now tell the patient to bend forwards and now check the distance between the 2 points. If the expansion is less than 5 to 6 centimeters, it is considered that the flexion is limited. So when you check on the ruler, now the marking should be raised, the distance should be beyond 20 to 21 centimeters. This is called a modified Schober's test. So as I said, if you are doing a proper examination of a patient of spondyloarthropathy, it is important to do this test and it does not take too much time. only you need a proper tape to examine this. In patients of spondyloarthropathy, or wherever you are suspecting a spondyloarthropathy, you will also see for chest expansion, because as you know, in patients of ankylosing spondylitis, there is also involvement of the rib cage, of the dorsal spine, of the costochondral joints. So there will be limitation of motions of the chest, and the chest expansion will be limited. See for tenderness around the SC joint, and also for costochondritis. As we said, also see for neck movements, which might be limited in a patient of spondyloarthropathy. After that, you are going down. Sorry, I missed this, the ankle joint movement. So when the patient is sleeping only, you are going to see for flexion. You are going to see for dorsal flexion, for plantar flexion, for inversion and eversion at the ankle joint. Also, don't forget to see for the metatarpophalangeal squeeze, as we did for the MCP squeeze. Don't forget to check for pulses. So again, the upper limb pulses, the lower limb pulses should be checked. Many times the patient will come to you with complaints of claudication. You do not know whether the claudication is neurogenic or whether the claudication is vascular. So when you check for the DPs and the PTs, and if the dorsalis pedis is well palpated, you know that this is not the cause of claudication, and it could be a neurogenic claudication. Also, when you are at the ankle, other than the ankle movements, you can have tendo-Achilles tendinitis, which is seen usually in patients of spondyloarthropathy. The first MTP is a common joint to be involved in gout. So you can see the acute swelling also, or you can see for the gouty tophi. The first MTP is a common joint to get gouty tophi. Many times the patients do not have any inflammatory arthritis, but a lot of foot pain and tenosynovitis, which is because of flat feet. So don't forget to see for that. Tell the patient to walk in your OPD. See for the loss of the arch. If the patient has flat feet, most of the time these patients can develop tenosynovitis around the ankles. And slowly, these patients also develop an osteoarthritis of the ankle, which is not because of any inflammatory arthritis, but because of the patient's flat feet. And this causes a lot of stress on the tendons, leading to a lot of joint problems. We should know this because in these patients, the treatment consists of very simple treatment of giving footwear modification and not a lot of medications. Again, when you are on the lower limbs, other than the joints, you are going to see for rashes, ulcers, erythema nodosum. So if you see this, these are purpuric rashes, which are generally seen in small vessel vasculitis, Henoch-Schönlein purpura, or even in post-viral vasculitis. This is just like, mosquito bite. So a elevated tender erythematous nodule is called erythema nodosum. So look for these. So many times the patient is having leg pain because of such erythema nodosum. Unless you check for this, the patient might forget to tell you whenever there are just one or two nodules. Like these ulcers over the lower limb, of course, you're not going to miss them. So the cause for such ulcers could be vasculitis, could be pyoderma gangrenosum. The only answer we will get by doing a biopsy of such lesions, but it is important to clinically see where these ulcers are, because sometimes ulcers on the medial aspect are because of varicose veins, and these ulcers definitely are because of something bigger like vasculitis. Now this particular patient had pyoderma gangrenosum on histopathology. Now see this patient has a digital gangrene. Also, this patient has a large ulcer on the foot. This patient actually had a polyarteritis nodosa, a vasculitis. So this is causing both the gangrene of the toes as well as this large ulcer on the foot. This patient had SLE. She developed these small ulcers, but very painful on her lower limb. On biopsy, this ulcer showed livedoid vasculopathy. So whenever we are examining any patient, it is very important, especially of connective tissue diseases, to see for these rashes, to see for these ulcers, to see for their location, to see for the morphology, see for the depth. All this should be done when you're examining the patient. It's very important, as we started with, that rheumatology is a multi-system disease. We cannot forget to examine all the systems. If not in great details, you have to just examine them quickly. Now, the respiratory system linked to connective tissue, many times you can have interstitial lung disease. So it is important to auscultate for any crackles and crepitations. Cardiovascular system. So many of our patients of connective tissue disease have associated pulmonary hypertension. So see for a loud P2. Many times these patients are in cardiac failure because of the pulmonary hypertension. So just have a quick examination for that. Some of the patients of lupus can develop pericardial effusion and pericardial rub. So see for that when you are examining a patient. The neuro examination you are not going to do in great detail. But as I said, in rheumatology, the patient can have a muscle weakness, a myositis, can have a nerve involvement as in mononeuritis multiplex. So the patient can have a foot drop. The patient can have a mononeuritis multiplex involving your hand. So whenever you have a quick examination of the grip, it is going to rule out these things. Always see for the power. Whenever you examine the shoulder, see for power of the proximal muscle. Whenever you are examining the thigh, see for examine power at the thigh. Whenever your power, you also, when you're telling the patient to get on your examination table, if the patient can quickly climb on your examination table, you know that the patient has a good power in the lower limbs. See for any high steppage gait, see for any, so this short, small things should not be missed when you're examining the patient. So, as I began with, at the end, I am again telling you, by all this, you must have come to know that in rheumat, along with history, a clinical examination is of utmost importance. Many a times after a good clinical examination, we actually send the patient without a single investigation to be done. So if you have examined and said that the patient has tennis elbow or a frozen shoulder, why do you need any other investigations? Nothing is required. So if you see, only the lab is only supportive and has to be done in only some patients where it is needed. Sometimes we can just diagnose it completely on your clinical examination. Thank you very much. Any questions?
Thank you, Neena. Fabulous. Absolutely well said. Absolutely clinical.
Thank you, sir. Thank you.
The session is open for questions now. I think the session was so good that we really don't have any questions as of yet.
Very true, very true.
Understood everything. Really.
Yes, yes.
Thank you very much.
Very well done.
Thank you, ma'am. Thank you so much.
Very good lecture, Neena. Very
Thank you,
clinical.
madam. Thank you. Thank you very much.
Anybody, any questions? There's a question from Faria. OA, clinical signs of joints. You know?
Yes.
Small joints.
Yes. So in OA, as we mentioned, along with the knee, a common involvement of osteoarthritis is the DIPs and the PIPs. You will see a lot of bony swellings in the distal interphalangeal joints and the proximal interphalangeal joints, because the DIPs are mostly spared in rheumatoid. So they are involved only in psoriatic arthritis and in osteoarthritis. But when there is gross bony swelling in all the DIPs, it is mostly because of osteoarthritis and not because of psoriatic arthritis. Also, you will see that there is not much of tenderness. So there is more of bony swelling. The tenderness and limitation of motion will be minimal. So in these patients, we need to just reassure them that, nothing is going to go beyond this. The fingers might look a bit crooked, but they are not going to affect your life. And we just give simple exercises like ball exercises, nothing more to be done. In the knee, again, as I said, see for crepitations. When you're examining the joint, you can feel it with your hand. The creps in the, even sometimes the patient can feel it themselves also, that they say that I can hear a crackling sound when I'm bending the knees. So this is for osteoarthritis.
Neena, any
Just to
sense to differentiate from psoriatic arthritis and rheumatoid?
Yes, sir. Sorry.
Any points to differentiate between rheumatoid and psoriatic arthritis for everybody?
Yes, sir. So, one thing is again the sparing of the DIPs in rheumatoid arthritis and the involvement of the DIPs in psoriatic arthritis. Again, in psoriatic arthritis, you will see more of a dactylitis. So, the entire finger might be swollen like a sausage. So, it won't be only the PIP joint or the DIP joint. You will see a sausage-like finger, which is called dactylitis, which is very typical in psoriasis because it causes the entire tenosynovitis rather than only a joint involvement. They again might be enthesitis, like involvement of only the tendoachilles, and also involvement of the axial skeleton, which is common in psoriatic arthritis. So generally, rheumatoid will not involve the lumbar spine, while psoriatic arthritis can involve the lumbar spine and the sacroiliac joints also.
In addition, you won't have nail changes in rheumatoid, which you would
Yes.
have in psoriasis.
Yes, ma'am, absolutely.
Even for the scalp, in addition to looking for alopecia, even you can see for the dandruff and the scaly lesions in the scalp, which again the patient may think it is just dandruff and may not correlate it
Absolutely.
with the joints.
Absolutely, ma'am, absolutely.
One question, how to differentiate viral from other arthritis?
Okay, good question. So now here your history is very important. So while examining a patient having a post-viral arthritis and a rheumatoid arthritis may look completely same. So there is no way clinically to differentiate between the two. The main thing is the history. So if the patient is giving you a history of even 1-2 days of fever followed by a acute polyarthritis, this goes in favor of a viral arthritis. If the patient onset is more subacute, so involvement of one joint, then involvement of another joint, it is going on over a few weeks, then you will suspect a rheumatoid arthritis. So asking a history of fever preceding the arthritis is very important. In fact, many times the patients of having post-viral arthritis, their legs actually look as if they have got cellulitis. So the legs are so bad and swollen. So they are differentiated, they are mistaken for having cellulitis.
Apart from fever, additional history of rash,
Yes.
itching, and even scaliness of the skin post fever would also be, helpful to some extent.
Yes.
During the chikungunya epidemic, we have seen so many patients having joint pains for a very, very long time. But we should remember that there is a non-deforming. So rheumatoid always causes a deforming arthritis, a erosive arthritis, whereas all these would be non-erosive.
Any other questions? What treatment is there for post-viral arthritis having severe pain? Also in reactive arthritis, does sulfasalazine hydroxychloroquine be used?
Okay. So, in a post-viral arthritis, again depends on when the patient has come to you. So, if the patient has come to you in a short duration, so the patient has got fever and has come to you with a history of only like 1 or 2 weeks of joint pain, this is not the time in which you will start any disease modifying agents, because many times these patients respond completely only to anti-inflammatories and steroids. So depending upon how bad the patient is, sometimes we need to give steroids also, sometimes only anti-inflammatory might suffice. So sometimes a combination of both also if the patient has very bad pain. If the pain is persisting beyond around 5 weeks and still the patient is needing to take painkillers and steroids, that is the time, even if it is a post-viral arthritis, we do add a disease modifying agent because it has been shown that it helps to reduce the duration of the illness. So in such patients, we do add drugs like methotrexate, hydroxychloroquine, sulfasalazine if the symptoms are persistent beyond 6 weeks. Reactive arthritis again is a sort of arthritis which begins generally after a bout of loose motions or a gastroenteritis. Again, the acute control is with anti-inflammatories. If it persists or if the patient is HLA-B27 positive, you might even consider adding sulfasalazine at an earlier stage. Otherwise, by norms, in a month of duration, you generally treat only symptomatically with anti-inflammatories and or steroids.
Neena, two questions, one short, one long. I think I'll take the short one
Yeah.
first. Is ONE warm at times?
Yes, sir. So ONE also, there is some entity which is also called inflammatory osteoarthritis. So the patient definitely has a osteoarthritis. There is no other joint involvement, but the knee might appear swollen. So this entity is called inflammatory osteoarthritis. In such patients, you might even consider adding a small dose methotrexate or HCQ later because there is an inflammatory component. Sometimes when a patient of osteoarthritis, because the ligaments are also weak, they might develop a ligament injury, a ligament tear, a meniscal injury, which again can cause the joint to become red and swollen. So again, history of trauma is very important when you see for any swelling in an osteoarthritic joint.
Yeah, the long one. Can you tell us about TB, tuberculous arthritis?
Yes. So in our patients, whenever the patients have arthritis and when you are going to put the patients on any disease modifying agents, we always even screen. So other than whether you're suspecting a TB or not, you screen the patient for a chest X-ray because tuberculosis itself can cause a reactive arthritis called Ponson's arthritis, in which the patients can have a typical involvement like a rheumatoid and have tuberculosis in the background. So this is a sort of reactive arthritis to the TB. Now, many a times, even the patient does not have Ponson's, but you have a tuberculous patient, you put the patient on AKT. Now, this scenario is more common than the earlier scenario. So, when the patient is put on AKT, the patient comes with severe joint pain and swelling. So, there are two reasons for this. Sometimes the drug itself can cause hyperuricemia, and hyperuricemia can give rise to this sort of pain. So,
Dr. Jategaonkar, could you mute yourself, please?
Mr. Shrikant,
You have to mute everybody.
Mr. Srikanth?
Mr. Shrikant,
Prasad, admin, can
Prashant,
you
mute
mute
everybody. Na?
Mr. Srikanth?
hello.
Prasad, can you mute Srikanth?
Hello.
I think go ahead, Neena.
Yeah. So in patients, they might come with a polyarthritis post AKT, which might be due to hyperuricemia, which again might be due to a Ponson's. So even after giving AKT in the first few weeks, you might develop a polyarthritis, and again which might be due to the drugs also. So in such patients, because the patient is already on AKT, you cannot give anything much because of the fear of hepatotoxicity. You treat the patients with a low dose steroids and an anti-inflammatory and observe the patient of the symptoms. Sometimes you might need to stop the pyrazinamide also if the patient has severe hyperuricemia.
Okay, and we have one more question. Neena, migratory polyarthritis, DDs and something more about it.
Okay. So again, even patients of rheumatoid can come what we call this as a palindromic arthritis. So not necessarily they might be a polyarthritis at the same time, but they might be involvement of one joint. After 2 days, it might jump to another joint. After 2 days, it might jump to another joint. So a patient of a proper seropositive RA also can have this palindromic arthritis, which can seem like a migratory arthritis. Again, rheumatic fever was a common cause of migratory arthritis, but actually we are seeing very less and less of this disease now. In fact, most of these patients are misdiagnosed with a positive ASO. So actually it is a good point because many times the ASO is high and these patients are labeled as having a rheumatic fever and started on Penidura, while ASO will come high even in a normal streptococcal throat infection. Even in a streptococcal throat infection, you can get a reactive arthritis. So a positive ASO does not mean a rheumatic fever. We are hardly seeing any rheumatic fever nowadays. These patients are generally just a post-streptococcal reactive arthritis or the ASO is falsely positive, and mostly they have inflammatory arthritis or reactive arthritis.
Yeah, if I have to add some more causes, gonococcal arthritis and somebody in whom the person is admitted, it could be bacteremia as well. Not so much for an OPD patient, but somebody who's admitted.
Absolutely.
Neena, Still's disease. Any comments on joint involvement in Still's disease?
Yes. So Still's disease is a common cause even in adults of fever, rashes, and arthritis. So in this, at the beginning, again, it could be fleeting from one joint to another. In the beginning, the joints, there are no deforming arthritis and still disease. It will be associated with rashes. The rashes might come and go and they would be fever. Later, sometimes the patients of adult stills also go on to develop an arthritis just like rheumatoid arthritis. So they might be having a persistent articular involvement which needs to be treated like a rheumatoid arthritis.
Yeah, let's take two more questions. We have another 5 minutes in hand. There's one question from Praveen. How do we confirm osteoarthritis apart from clinical picture? A case of elderly female hypertensive has lower limb edema bilateral since 5 years. Significant pain in knees. Medically, other workup is all negative. Heart, kidney, thyroid, anemia is negative. What do we need to rule out in this case, or should we send something and reports? I think.
Okay. So whenever you want to, if you're confused whether this patient, so it can happen as Dr. Shashank had asked, कि sometimes there might be swelling in the knee. So this patient could have even a involvement of the knee in rheumatoid arthritis. So sometimes rheumatoid itself can only cause a knee involvement. So if you're confused on clinical examination whether this is an osteoarthritis or a rheumatoid, definitely whenever there is an effusion, we do send the rheumatoid factor anti-CCP. You get an X-ray done. You can get an MRI where you're not sure. So MRI is done in many patients which we are unsure to see what is the cause of arthritis. Again, a single joint involvement can be even in a tubercular arthritis. So if you have a single knee joint which is inflamed, could be even having a joint infection. So an MRI can be done. A good soft tissue ultrasound will also give us a lot of information whether there is synovitis. So if you don't want to go ahead with an MRI, if you have a good center which can do a USG and tell you about the effusion of any loculations, that also should be good enough. Again, as you said, your patient has lower limb involvement also. If there is ankle inflammation, again, you can think in terms of systemic illnesses like rheumatoid and send the necessary workup.
I think we have just a little bit of time for one last question from Faria. What is palindromic arthritis and how is it different from migratory polyarthritis?
Okay, so palindromic arthritis is the duration of the joint involvement may not be like just 2 days. So the patient might come to you ki I have one joint involvement with or without medication. That joint involvement may go off within 2-3 days. Sometimes 15-20 days also the patient may not have anything. Sometimes for a month also the patient may not have anything. So this is called palindromic arthritis. It is a special entity, a subgroup of rheumatoid arthritis. We have to treat these patients just like a rheumatoid. In these patients, many times your CCP, rheumatoid factor is positive. But clinically, when the patient comes to you in the middle, you may not find anything on clinical examination because they have come to you in the middle of their 2 episodes. They might have a completely normal systemic examination. But when they have the episode, the joint is very much inflamed.
Yeah, practically what you can do in these patients is ask them to keep a photograph. So whenever they have an episode,
Yes.
so many times when they come, it's nothing. They're absolutely
Yes,
normal.
yes.
You're not able to see anything. So a small, thing like ask them to keep a snap of the this thing during an episode is something that is very useful.
Yes.
So then we are coming to the end of our second session. Thank you so much. Another 2 weeks from now, we are going to have our next session. I would be taking up that session and we would be looking at approach to a patient with multiple joint pains, body ache. So we have looked at how to take the history. We have also looked at how to examine the patient. Now the logical next step is how to approach a patient who comes with either multiple joint pains or body ache. So it could be inflammatory or non-inflammatory. How to go about it? Having had look at the basic things, basic steps that we do for a patient. So looking forward to see you again after 2 weeks. And thanks again, Neena. Wonderful lecture.
Thank you, sir.
Wonderful.
Thank you,
so
sir.
much.
Good day. Bye-bye, everyone.
Bye, everyone.